and Dr. Tyler Evans. How are you, sir?
I'm doing great. Dr. Kevin Leach, how are you?
I'm well, thank you, sir. So we're going over a research paper today called Symptomatic Reactions, Clinical Outcomes and Patient Satisfaction Associated with Upper Cervical Chiropractic Care, a prospective multi-center cohort study. And this is by Dr. Kirk Eriksen, Roderic, Rochester, and Eric L. Hurwitz, and it's published in the Biomed Central Musculoskeletal Disorders Journal. We got everything there?
Yeah.
All right. So if you would, Dr. Evans, will you just do a quick overview for people that, I mean, we're going to obviously get into all of the details of the paper and do a real deep dive into it, but can you just do a 50,000-foot overview of the paper and what it's showing? What were they trying to answer? What did they accomplish? That kind of thing.
Yeah, no, that's great. And so overview of this paper is that it was a 1,000 patient study over 83 different upper cervical chiropractors offices of all of the different types of upper cervical chiropractic. And what they found was that they did 2 weeks of care and they tested before and then tested after. And they found roughly, 4.5 per patient office visits requiring 2.4 adjustments over those 4.5 visits. So only half the time they adjusted, which is kind of cool because that's an interesting thing for upper cervical. We'll talk about that more in a minute. 31% of patients had what we call a symptomatic reaction. We'll get into what that is in a minute. Let's see, it was intense symptomatic reactions, which are a level higher, occurred in just 5% of patients. And the, basically the satisfaction on a numerical rating scale from 0 to 10 was scored a 9.1 on average across the board for all the people. And out of 5 million, a little more than 5 million career upper cervical adjustments, there was a question on the questionnaire for all of the 83 offices. They added up all the adjustments that all those 83 chiropractors had done in their careers. They had never once had an adverse reaction, which is like the highest kind of reaction, and that would be a time or situation where the person needed to go to the hospital or there was a death or something very, very, very serious. So out of 5 million career upper cervical corrections, not once did they have a problem in which something like that occurred. So this is a first time ever paper, and it was a really great paper, and yeah, let's get into it.
Awesome. And so let's, I'm just going to explain a little bit, because there's a lot of different people listening, what the difference between upper cervical chiropractic and what that actually means compared to your traditional. A lot of people hear the word cervical, right? And they think something else. And when we're talking about that, obviously that means the neck. So upper cervical chiropractic being different than traditional, meaning we focus on the neck, and that's because of the anatomy, the neurology, just how complex that area is compared to the rest of the spine. And so we're doing techniques that adjust and align that area that aren't your traditional spinal manipulative therapy techniques with the rotation and the popping and the typically like the cracking sounds that you would hear with that. So there are specific techniques, I would say maybe 8, 9, 10 around that only address the upper neck. And in doing so, it actually addresses the entire spine, but that's a lot of neurology that maybe we won't get into at this point. Maybe we can do another show on that. Okay, so that's a good overview for anybody that, again, just wants the cliff notes. Any other, just to kind of 50,000 foot, perspective, just to kind of a take home for anybody listening here, like the value of this study? How can they use it in their practice? How could, you know, sharing it with family members, any other takeaways?
Yeah, I mean, there's just a couple interesting quick takeaways. One is that this paper actually showed a, let's see, it was a 57% improvement in their Oswestry Disability Index, which is for low back pain.
Right.
And that actually compared on par, if not better, than other general chiropractic guidelines in terms of low back care improvements. So something you may not, you know, expect to hear coming from an upper cervical study, but what we found is that when we balance that head over the neck properly, the lower back actually had quite a great benefit. A lot of people wouldn't think that or know that. It was just kind of a side effect of them studying everything in this paper.
Right. Right. Great. Cool. All right, let's go ahead and get into, let's just get into the background. You know, so we'll go through the background methods, right? Discussion, conclusion, all that kind of stuff. And we'll just start with the background. As far as what does if we compare, I guess just upper cervical with traditional chiropractic and just the overall research and what's available, what's kind of the comparison? I believe it said that this is actually the first study that's been done showing the safety of exclusively upper cervical techniques, but I've also heard someone else say that there was a lot more. Do you know anything about the details of that? If there's any other specific studies like this one, or is this kind of like a breakthrough, one of a kind study here?
Yeah, absolutely. So, you know, I'll just break down the title real quick because it might be a little bit hard to understand, but symptomatic reactions are reactions in which there is a slight increase in a symptom, either, you know, neck soreness or back soreness or some sort of symptom. So they wanted to study that because a lot of times chiropractors, or at least in general, the guidelines in terms of research, there's some negative information that's put out there, and they wanted to kind of like show upper cervical's power in how it works, and that the symptomatic reactions are often quite short and in low severity and frequency. And then clinical outcomes, so that would be the neck pain disability index, the Oswestry disability index. So those are two questionnaires that people did before and after that actually break down out of a 100-point scale, specifically how their neck pain affected their ability to do their life or their low back pain. And so then the patient satisfaction was rated in a numerical rating system from 0 to 10, or 0 to 11, you know, 10 being the best that it could be, and the 0 being the worst that it could be. And then a prospective study, and that's why this study is unique, is that prospective means it was done, they planned the study in advance. They laid out the terms of the study to, I think it was 110 chiropractors. They only chose to work with 83, or 83 only chose to work. And so they planned it in advance. They then applied the parameters to these 2 weeks of care. And it was a multi-center, meaning multiple chiropractic offices, meaning
right
across the country. There were 4 different countries actually involved in this study. It was Spain, England, United States, and Canada, which is kind of cool. That's an amazing thing that we can do that in our upper cervical profession. And then a cohort, just meaning a group. So it was the first large group study across many different upper cervical techniques that had ever been done. I think it's still the only one that's ever been done like that. So Dr. Eriksen and Dr. Rochester, they're 2 of our mentors, Kevin and I, Dr. Leach, and we were lucky to know these guys because they did something for our profession that you know, hopefully we can continue to do, but they laid a great foundation and you know, great way to move forward with some great statistics.
Got it.
Yeah, so that's why it's special.
Okay, I like, and also just to go into a little bit more detail about symptomatic reactions as opposed to adverse events.
Right.
So they chose in the study to use symptomatic reactions because in actuality, some of those symptomatic reactions are expected. And so they didn't call them side effects or adverse events, which would imply that there's a negative connotation to what's happening with the body. And because some of the symptomatic reactions that were recorded were actually, for example, breathing easier was a symptomatic reaction, which some would say is a very welcome side effect, and also digestive improvements or things like that. So they recorded all of these, even if it was positive or perceived as negative, like maybe some soreness or even some headache afterwards. So they defined it as symptomatic reactions. I think that's an important point to make.
Yeah, absolutely. And Kevin, if I can add to that, you know, there are terms that we use in our office sometimes of retracing and restructuring, and I'm not going to go into that here, but the point is that healing is not always linear, and the research in PubMed is designed to study a thing over time and take out the variables, and it's really hard to do that in the human body, especially when you're talking about manual therapy, which is the global what we do. And symptomatic reactions happen, and they're a good thing at times. You know, they can be very important to the healing process, and that healing is not linear. So that's an important thing for people to remember, and that these symptomatic reactions are short in time, in duration.
Yeah, mostly less than 24 hours.
24 hours.
Is that correct? I think it states in here.
Yep.
Yeah, that's huge. Yeah, and definitely maybe we'll get into a little bit of that at the very end as far as discussing how we see this in our own practices, because I think that's important. And there's some ways that I definitely explain to my patient about what's going on with the body, and it's just a healing process. Just real quick, for example, someone hasn't gone to the gym in a year. They go to the gym, they work out, they're sore the next day. It's not that that's a bad thing. It's it's uncomfortable, but in the end, it's gonna be beneficial. And so there's some parallels there to what we do in practice. All right. So let's see. Let's head into the, well, actually, let's go into just real quick. Let's talk about research in chiropractic in general, real quick before we head to the methods. For example, when people look at research and they say, well, who funded the research and who did it? And are there biases? Are there, complications that way? And I think it's really important to, not merely make excuses for the profession, but to really make it clear that there's no National Institute of Health. There's no huge conglomerations that are paying for this research. So when research is being done in chiropractic, if anybody wants to get research done, we have to do it ourselves. So yes, we are, we see results in our office and we see amazing things, and we want to prove the efficacy and the benefits of research, but we're the ones who have to fund it. Typically, it's doctors who are taking time out of their own practices. They may or may not be getting paid for it, and if they are, it's not very much. They're doing it to advance the profession and to just create more research and to ultimately help more people. I think that's a really important point, because a lot of people will say, oh, it's chiropractic and it's funded by chiropractic. Of course you're going to have, good results and you're going to see good things. But I mean, that's where we are right now. Do you know if there's any advancements or any newer situations happening where we're going to have any funding from people like the NIH or any other big studies that are going to happen that come from outside funding? Do you know of any?
Yeah, well, so in terms of the NIH, I do know that, and we can at some point go over this paper as well, but the Dickholt study at Palmer, which you went to Palmer, you know, I think that after you and I graduated, at some point after 2008, they did actually, because that paper was so foundational and groundbreaking in terms of like studying one thing, high blood pressure, or actually blood pressure changes as a result of the Atlas correction. The NIH did grant them, I think it was like $1 million or something like that, to do a study, and that study has been not taken to full completion yet, and I'm not certain as to why. But that's part of the problem, is that in chiropractic we just don't have the infrastructure, and we need more infrastructure. We need, you know, we need more people doing research. One person in general that I know that is out there doing this, that's not an upper cervical chiropractor, but actually it's interesting, a lot of her stuff points to the cervical spine as a place of big input into the body and change, is Heidi Havoc. And
Right.
she's down in New Zealand, and she is doing some amazing research. And I think she does get grants. I just don't know where they're from, if they're from the NIH or what, but she is a legit clinical researcher down there in her lab making cool stuff happen. And a lot of her papers are, and you know, at some point we could review her stuff. But yeah, so this paper, you know, it was done, like you said, by people that took time out of their practice, and that's our rough spot, is that most of our stuff is just case studies, and a lot of times people don't take that as like a burden of proof, and you know, we're in a tight spot there. So yeah.
Right. Cool. All right. Well, I actually looks like I got a little bit ahead of myself, because talking about the funding and the conflict of interest is in the methods, which is just what you went over. I think it was actually funded from the Orthospinology Association. Is that's who did it?
Yeah.
The IRB of the Life University, the chiropractic school in Atlanta.
And the IRB is so every chiropractic college has an I believe it's International Review Board, I believe, or Internal Review Board, something like that. But that is that's at every, well, it should be at every chiropractic college, and so you always have to get this IRB approval before you do a study, especially with humans, because you know we don't want to be doing things to people without having it reviewed and peer published and tested, you know. So the IRB thing is a big deal, and getting, you know, papers approved is actually quite hard. So you know, that's an important piece of doing research. Got
it. As far as breaking down, as far as methods, I think there was 8 different techniques that were used in the study, 7 maybe. Do you think we should break that down and kind of explain them, or do you think maybe just given, it might be too much, right? Maybe we can do that another one. How about just maybe the difference between the orthogonal and the segmental? You just break that down real quick?
Yeah, so, and when we talk about upper cervical, we always discuss orthogonal and articular, because segmental would be full spine chiropractic. Articular meaning we're specifically looking at the articulation between C0 and C1, and orthogonal meaning we're looking at the orthogonal relationship between the head and the lower spine and the cervical spine, and the rest of the spine. But yeah, so, you know, just to break it down really quickly, in the 1930s, there was 1 or 2 guys, B.J. Palmer and Alec August Warensing, that developed this style and idea of correcting the cervical spine, the upper cervical spine, to balance the head because of its specific relationship to the rest of the spine, the fact that it doesn't have a disc above or below. And what they found was that they developed a whole new science in chiropractic, and really in health, and understanding how the neck can affect the whole body. And so we have all these techniques that branched off, but it's really broken down into 2 specific types: the orthogonal types and the articular types. And orthogonal being Atlas orthogonal, advanced orthogonal, Epic, who was not in this paper because they weren't in technique yet. Also, Grostic, Orthospinology, that's who funded the paper, and NUCA. I don't think I'm leaving anyone out there. And then the articular types are the Toggle group, the Blair group, and the knee chest group. So there's really 3 groups in the articular group. And so that's kind of the breakdown on that.
Got it. I'm just gonna, just for the listeners out there that might not be completely familiar, when Dr. Evans said COC1, he's talking about the relationship between the head and how that sits on the very top bone of the neck. And so also the word orthogonal, if you think about crosshairs on a rifle, and you think about the head straight up and down in relation to the top bone and the neck, and then the rest of the neck as well, everything being nice and aligned, no head tilt, neck deviation, things like that. And articular meaning related to what's going on with the joints, and looking at the joints and seeing if they're aligned, and seeing if it's maybe right or left or slipped in certain different ways. So again, these are slight nuances. And just, I think as Dr. Brooks would say, it's just a box, bunch of different holes, and you're just looking into the box from different perspectives. So these techniques just developed, we want the end goal, and that's just the health and the proper function of the upper neck. But these different techniques are just different ways to get to it, based on different, slightly different analyses. So, yeah. Okay. All right. So, let's go into, if you would, maybe talk about just all the methods, just starting with, the inclusion criteria, and just kind of go from there.
Okay. So the inclusion exclusion criteria, the patients were aged 18 to 85. There were 10 cases per chiropractic office. Some offices had less just because of things happen in life. But that was the plan there. And then the data collection, clinical outcome variables, the way they studied the data was they did a neck pain disability index and an oswestry disability index pre and then post 2 weeks of care. That is a limit to this paper. It was only 2 weeks, right? So right. A greater paper, just to follow up on it would be to follow up on these patients maybe 6 months or a year later and see, how they're progressing. But the intervention was upper cervical chiropractic only. The reason we do that is because what we find with the upper cervical spine, it is very, very susceptible to movement lower down. And so if you are putting a force in somewhere else in the spine, it can actually change what's happening up top. And so this was upper cervical chiropractic technique only. That's what the UCT stands for in the paper, and that's special to denote, because this is the difference in what we do, is that we're only working on the top, 1, 2, maybe 3 or 4 bones, right, depending on who it is, but really the top 1 or 2, and that's what makes us different. And then the re-exam and clinical outcomes were two weeks later. They did a follow-up, and they did the neck pain disability, the oswestry, and the numerical rating score. Patient satisfaction, the way they tested patient satisfaction was by asking 3 questions. So how satisfied were they? And then so it was how satisfied were they? And it was on a scale of 0 to 10. Sorry, not 3 questions. And then the symptomatic reactions, they had 13 specific areas that they looked at. So one was neck pain, one was radiating pain, like down a limb, an arm or a leg, arm or leg weakness, tiredness or fatigue, headaches, dizziness, nausea, vomiting, tinnitus, blurred vision, confusion, depression or anxiety, fainting, low back pain, and then there was a space for other symptoms. But that's pretty, all encompassing there. And those things might sound intense, but oftentimes, Kevin, I don't know if you feel this way, but I know that in my practice, a lot of the patients that come in, they come in with all that stuff. And right. So, if we're working with a patient, they may have that just because of that's their symptomatology. And
Right.
so what we were trying to determine in this paper was, did that increase? Did it stay the same? Did it get better? You know, and so yeah, so that's where we started out with there. Intensity was also graded on a scale of 0 to 10. Duration was graded from 0 to 30 minutes. That would be the symptomatic reaction happened over 0 to 30 minutes. It was either then 30 minutes to 4 hours, sorry, which would be a bit longer, and then 4 hours to 24 hours, and then more than 24 hours. So, and that's actually when that symptom started. So if a symptom started at 24 hours after the first correction, it was graded as that level. And then finally, the patient was asked to indicate the impact on daily activities for each symptomatic reaction, like, did it affect life? Not at all, a little, or a lot. And then the Rubinstein et al. Guidelines for how symptomatic reactions were defined was used, and that was a new or related complaint that was not present at baseline, or a worsening of the present complaint by greater than 30% compared with baseline occurring 24 hours following care. And any intense symptomatic reactions were identified as complaint fulfilling the score greater than or equal to a numerical rating scale of 8, which I believe we said it was 5%. And then that's not to be confused with a adverse effect, which was a life-threatening situation needing admittance to a hospital.
Right.
Okay, so that was
Got
the
it.
breakdown.
Yeah, cool. So that's the methods. So as far as results are concerned, so like you said before, there was 115 doctors, 83 were included from the 4 different countries. The average number of years that they were in practice was 13. The average number of adjustments for each of those doctors was about 85.5 adjustments per week. 48, 49 weeks of practice per year. Average number of career adjustments, 61,000, with a total of over 5 million for all the doctors that were involved in the study. And I think they included this to show maybe the importance of their experience. Why was that included in the study?
So the reason that was included into the study was because of there have been a handful of papers in the past that were pointing at chiropractic as a source of adverse events, meaning stroke or other crazy things that had been blamed on it. And what they found was that with upper cervical chiropractic care, in 5 million adjustments, they didn't have any, right? And so that had been said that at a minimum, within 300,000 adjustments, regular spinal manipulative therapy had caused or possibly caused a stroke. And so that's, a much deeper conversation, but the reality is that, the Cassidy study, if you guys are out there listening, you can go look up the Cassidy study. But what we find is that it's not that chiropractic or spinal manipulative therapy causes strokes. It's that oftentimes people are in midst of a stroke and come in because they are complaining of numbness and tingling in the face, neck pain, head pain, weakness. These are the things that we see our patients for on a regular basis. And so then they go to the ER and if someone had been to a chiropractor, oftentimes they get, they start to place blame, right? And so we just want to put that out there that this study showed that in 5 million visits, that there were no adverse events. And so that's just a product of statistics.
Yeah, and I think that study is going to be one that we're going to review in the future, because I think of how important that study is. It's really important to show these studies that really show no causation, possible correlation, but no causation, and that's the exact mechanism that's thought of as far as how Unfortunately, because we see those conditions all the time, sometimes those slight nuances and those red flags of knowing that the patient is actually having a stroke before we adjust their neck to hopefully make it feel better, sometimes that's not caught. They get adjusted. They go to the emergency room. Where have you been? Oh, you went to the chiropractor. Oh, it caused a stroke. And so I'm not sure if it's the Cassidy study, but I know one of them shows that the risk of a patient having a stroke, meaning, whether it's at that point or later on, is the exact same as if the patient went to a medical doctor who's not adjusting or manipulating the neck. It's literally the exact same, which
that's Cassidy.
Exactly. So that's why the thought process is, well, if they have the same quote unquote risk to go to the medical doctor and the chiropractor, it's most likely happening already, and the medical doctor refers to the ER, the chiropractor refers to the ER, or they go to the ER after and they find that they're having a stroke. But obviously they don't say, oh, the medical doctor caused it, because they didn't do anything to their neck. Right. So that's a good study that we'll get into.
Yeah.
And before we head on to this next point here, I like to kind of just you talked a little bit before, it might confuse some people about how a certain amount of adjustments were done and there were a lot more visits than adjustments. So a lot of people that have been to a chiropractor or who know about chiropractic, they might wonder, why would you ever go to a chiropractor and not get adjusted? And I think it's a really important point that many chiropractors, but definitely most upper cervical chiropractors, our entire goal is to get you adjusted and get you aligned, but not do it every single time, just for as like a treatment or a symptomatic treatment, but to kind of train your body to be in alignment. So these next percentages, for example, 31% required only one adjustment over those 2-week periods. They might have gotten checked 2 times after, but found that there was no treatment actually necessary. There was no adjustment actually necessary because they've actually held their alignment. 28% needed 2 adjustments, 19% needed 3, 11 needed 4, and then 9% possibly more than 4. So that's a really important point to understand, is that there's a lot of testing going on before actual adjustments are being made in upper cervical offices. Mm-hmm. Another point, 74% of the patients seen in the study were considered chronic. So that's important to understand, especially when you think about sensitization of nerves and pain and chronic pain and all that kind of stuff. 74% chronic complaints with mild to moderate disability and moderate pain. So pretty, fairly serious patients coming in for the study. And with the satisfaction rate and the results that we got, I think we're pretty happy about those results.
Mm-hmm.
You want to talk about the outcomes?
Yeah. So let's see here. Are we talking about, so, okay. Over the course of treatment, neck pain improved 56.8%, which is clinically statistically significant. So when we talk about a result in a paper in PubMed, we always want to find that it's statistically significant, meaning that the procedure or the treatment that was used was then shown to have some effect that is repeatable and reliable. And that's what this statistically significant means. So it just means that it brings some weight to, obviously that an upper cervical chiropractor has the ability to help with neck pain. Headaches were also improved 62.8%. Mid and lower back pain were improved 58.6% and 57% respectively. So, that's just showing that upper cervical care is effective for, in this case, and the way this study was done, is that it is statistically significant for helping with those issues. Disability from neck pain improved 47%. Oswestry disability for the low back improved 45%. All of which meet the chronic, the clinically and statistically significant. So, I think the big thing to take out of this is just that patients did these 2 weeks of care. It was a snapshot in time. we had a 9.1% rating in terms of satisfaction, and very low
9.1 out of 10,
out of
right?
10.
Yeah.
Yeah, out of 10, and a very low level of symptomatic reactions that were, I mean, they were common and quite frequent, but they were low in duration and low in intensity, and actually great statistically significant outcomes in terms of headache, neck pain, mid back pain, and low back pain. So yeah.
So we've got with all those high percentages of improvement, but then when we also compare that to just other articles, you know, again, major complications are extremely rare, right? Even it's actually common to have these slight symptomatic reactions, but
Right.
again, like you said, they typically go away pretty quick, and there's nothing that's really long standing. So that's important.
Yeah.
And as far as let's see. Just because we might be running out of time here, I was thinking,
Yeah.
what else about the discussion do you think might be good to talk about?
Yeah, I mean, I think the weaknesses of this study. It's always good to talk about the weaknesses. You know, this study was done for 2 weeks. Obviously, we'd like to see a study that's done over a longer period of time. That requires a lot of money, time, and effort from guys like you and me people like you and me that are out there just trying to help. So that pulls away from our practice, but it's something that we need to do. It did not show a risk analysis, so there was no risk analysis necessarily, but in terms of like a specific reaction, but it does show safety and efficacy, which those are important, you know, and that's a piece, right? So there's all these pieces that we have to piece together in the upper cervical world to show that, you know, when we do this treatment, we get this outcome. But it's just hard because we can't do our RCTs, you know, randomized clinical trials in an upper cervical practice. Are you kidding me? Like,
Yeah.
How do you do that? You know, it's just,
Yeah.
you can't give a sham adjustment in an upper cervical office. Like, it's really hard because everything affects the upper cervical spine. So,
Right.
you know, it's tough. But,
Right.
but yeah, I would say that's our limitation, and we need to keep doing more research. But yeah.
Cool. How would you say, you know, when I read this study and when we were planning on doing this, I was really actually, even with the mild symptomatic reactions that resolve less than 24 hours, even when I read that, I was actually surprised because, and again, I'm not trying to say I'm better or blowing my head up, but I felt like it was actually pretty high. And it got me thinking, as far as compared to my own practice.
Yeah.
And it got me thinking, like, are patients not reporting what they're feeling? Possibly because it's less than 24 hours. I see them 3 days, 4 days later, and so maybe they forget about it. But
yeah.
what about you? Do you feel like those actually were a bit high compared to what you see, or were those on par?
Yeah, I mean, I think that they're, yeah, there's times where I would say that some patients have some of that, and then I would say there's times when some patients just do amazing. And so, you know, it's hard for me to compare really because it's such a changing, evolving thing. But what I would say is that it's surprising to me, you know, really breaking it down, how effective upper cervical is at helping people and having such little negative side effect, and how satisfied people are with it. You know, a 9.1 out of 10, like in 2 weeks of care over, what was that, 1,000 different patients? Like, that's incredible. So yeah, I would say, because I can think in my mind, I've had a couple of people that have had symptomatic reactions where they were concussed like a few weeks before, and we got them corrected, and so they had a bit of a retracing cycle where you know, their headache got a little bit worse, or their brain fog got a little bit worse, and then they felt the best they'd felt in years. And so, you know, it's like, yeah, there's some of that, but
Do you tell your patients after the first adjustment, or maybe even the first week or two, that, hey, you might be sore, hey, you
Yeah.
might have some, yeah, and I do too. So it's interesting to think about the mechanism of that. And I actually, I probably tend to tell and explain too much to patients just because I'm passionate about what I
Yeah.
do, and maybe they don't want to know all the details. But I think it's important, and the mechanism being is that when you're changing the structure and the biomechanics and the way that the bones inside of your head and and your neck are moving and articulating, that in and of itself, when you're breaking up adhesion, scar tissue, that's going to cause a little bit of inflammation. Any sort of inflammation in your joints, you're going to get achy, you're going to get pain, and because there's a cervicogenic, a neck related headache that most have, you're going to have that response. And so I tell patients all the time, hey, listen, there's a possibility you might feel these, but this is normal. And unfortunately, I think a lot of our colleagues might not actually tell their patients that, because I've had several patients that I can remember say, oh, well, I went for a few visits and I was sore and it was painful afterward. And and it's like, well, they should have told you that was going to happen, because that's part of the healing process. Again, with the relationship of going to the gym and working out, like it's going to hurt for, like it's going to take a while before your body gets used to that, but it's still beneficial in the long run. I think that's really important for people to understand.
Absolutely.
Yeah. All right. We good? Any other points that you want to hit on before we close it out?
No, man, I think we covered it really well. I think that was pretty all encompassing. That's good.
Awesome. Well, Dr. Tyler Evans, I really appreciate your time. I know you're like 5 minutes away from seeing patients. We'll be doing this again. And so, yeah, thanks for your time, and have an awesome day.
Yeah. Thank you, Dr. Leach. This was great.
All right.
Let's do it again.
Awesome. Yeah. See ya.